Good afternoon, Doc. Do you want me to start the lecture now, or are you still waiting?
Greetings and good health to all participants of Class C student in 5th semester. Well, I invite Dr. Gita to start with, please. Thanks.
Okay, Doctor, I will just share the scenario first. Okay, so Assalamualaikum warahmatullahi wabarakatuh, and good afternoon to students of Class C. I hope everybody is well. Today we're going to be attending a lecture about head trauma, which you have probably already watched on your e-learning portals. So since we assume that you have already watched Dr. Dave's video, and I hope everybody has watched it, today we're going to go straight into a scenario discussion about head trauma. So in this part of the lecture, we want you all to participate actively to discuss this case. So there'll be a few questions for you to discuss. So let's start with the case. So there's one case here that we'll be talking about. First, I would like to show you the history, and please feel free to comment during this presentation if you have anything to say or if you have any opinions. Please just say it right away. So let me start with the history. So on the history, we can see that this is a 60-year-old male who was taken to the emergency room by his family after experiencing weakness on the left side of his body since the past 2 days. So let's all just highlight the time course here. So he's taken to the emergency room after experiencing weakness for the past 2 days. But if you read further, the patient was taken to the hospital after a family member with a medical background visited the patient and saw his condition. The patient has a history of a fall 13 days ago from a 3-meter high tree and subsequently bumped his head on the ground during the fall. After that, the patient was unconscious for approximately 15 minutes and then regained his consciousness. The patient also complained of a headache of medium intensity, which reduced to a low intensity on the 3rd day after his fall. 2 days prior to his emergency room admission, the headache increased to a medium-high intensity. There was no vomiting. The blood pressure of the patient during the fall was unknown, and there was no seizure. The patient has no previous history of hypertension, diabetes, heart disease, or stroke. So maybe before we move on to physical, does anyone have any comments, perhaps, on what are the important points that you can gain from the history? Maybe I'll start with Megan, who is the head of the class today. Megan, what do you think is a couple of keywords that you can highlight from the history of this patient?
The patient had a history of a fall 13 days ago from a 3 meters high tree.
Okay, so you've highlighted the fall, and it's from a pretty high tree, a 3-meter high tree. Maybe he was picking some mangoes, I don't know. And what else can you highlight, Megan?
And the weakness just showed up after maybe 2 weeks after that. So there is interval after the right. Trauma.
Okay, so that's something very important, and you've picked up on that. The fact that the patient fell 13 days ago, but his weakness only presented about 2 weeks later. So that is a very important point, and it's good that you have caught onto that fact. And can anybody else give me an important keyword from the history before we continue to the physical?
Could I maybe add something?
Yes, of course, Max.
Okay, so maybe the part where it says he bumped his head on the ground during the fall.
Yeah, that's very important. So as you've already watched from Dr. Dave's video, when we're talking about patients with head trauma, then it is crucial that you discuss the mechanism of injury. How did you fall? Not just when did you fall, but how exactly did you fall? And here we can see that he bumped his head, so there was direct trauma on his head. Okay, can you give me another word, Max, that you think is very important?
The fact that he fell unconscious for around 15 minutes.
Okay, so he was unconscious for around 13 minutes. Yep. One more maybe, before we move to the physical.
He complained of a headache of medium intensity, which then is reduced to low intensity after 3 days.
Okay. And then what happens afterwards to his headache?
The headache increased again to medium high intensity.
Okay, so we can see that there is a fluctuation in the neurological symptoms, as you can see from the headache, for example. He had a headache right after the trauma, which may have been caused by the direct effect, but then it fluctuated into a lower intensity and then into a much higher intensity. So that's something that you all should note before we move on to the physical. Right, so this is the physical exam. As we can see, his blood pressure, his heart rate, his respiratory rate, temperature, NPRS score, which is the pain rating scale. And the head is all normal. So we don't see any signs of trauma on the head at the moment. And his eyes show no abnormalities, no abnormalities in the neck, chest, and abdomen. So in general, what can we conclude from the physical exam? Anyone else? Maybe Alia or Alia, what can you tell about this physical exam? Do you think this is normal or it's not?
Based on the general physical exam result, it's normal, doc, but we have to do some neurological exam also.
Okay, fantastic. So that's right. There is no abnormalities in the physical exam, in the general exam. But let's have a look at the neurological exam. So maybe we'll start with Ira. So what do you notice from this neurological exam? Do you see anything abnormal from the exam? Are you aware? Are you able to read this? Have you seen this kind of written form of neurologic exam before? Do you know what this means?
Maybe the cranial nerve, there is a central paresis, doc.
Okay, so you've noticed that there is an abnormality here. So before we move, let's perhaps just have a quick run through the neurologic exam. So the GCS, that's the Glasgow Coma Scale. So he has a perfect score, meaning that he's well aware, he's well orientated, there is no loss of consciousness. Mental state is normal, there's no meningeal sign, and his cranial nerves, his pupil reflexes are normal. But as Ira has already stated, there is an abnormality of the cranial nerves 7 and 12. So please note that your patient now has a left side hemiparesis and also a left cranial nerve paresis of the 7th and the 12th cranial nerve. Okay, just write that down for our diagnosis section. Okay, now we move on to the other parts of the neurologic exam. Have you seen this kind of written form before? Because I asked the previous class and they've never seen this kind of, this is what maybe the clinicians like Dr. Dave sees every day in the hospital. Yeah, Dr. Dave, this is how we write down our neuro exam results. But I think since you are still in the pre-clinic, maybe you haven't seen this.
Thank you, Dr. Gita. We know this is a case of subdural hemorrhage because it is far from the pyramidal tract that runs in the subcortical area. It enters the internal capsula. It goes down to the brainstem. So it depends on the volume of the hematome where the edema affect the function of the pyramidal tract. So if the hemiparesis strength is 4, then the edema process trapped the pyramidal tract is not heavy, so the paresis of 7 and 12 nerve is only a central type shift, like a left side of hemiparesis, so a central type.
Yeah,
Please
thank you, Dr. Dave, for
continue.
the addition. Thank you. So when you enter your clinical rotations, you will be seeing these diagrams a lot. So perhaps you haven't seen it now, but you will be seeing this every day when you enter the neurology rotation. So this is how we write in the patient's status to indicate the results of the motor examinations. So perhaps you've already read, have you had the lecture on the physical exam in neurology? You know that the motor aspect is measured routinely. And when we measure the motor component of a patient, we measure a couple of things, not just one. We measure the movement, So go back to the history. What side is his weakness in? Right side
On
or
the
left
left
side?
side.
Good, Megan. So you remember that it's on the left side. Now you just confirmed it with the physical examination. As you can see, the weakness, the movement, the arms and the leg movement is reduced on the left side. So you just confirmed that on the physical examination. And now we look at the strength. If you recall your physical exams, we know that strength is indicated from a range of 0 to 5. And here 5 means perfect strength, whilst 4 means slightly reduced strength. So we can read more about that later in your clinical skill lab. But here we can tell that on the left side, he has reduced strength. Okay, is that clear? So he has reduced movement on the left side, reduced strength on the left side, and now we see that he has reduced tone, muscle tone also on the left side. So this fits perfectly with your previous examination. And then we can see that he has reduced physiologic reflex and a positive pathologic reflex, all on the left side. Now let me just go back to the class. Do you still remember what is the name of the pathologic reflex on the upper extremity and on the lower extremity?
In the upper extremity, I think it's called Hoffmann-Tromner, and in the lower extremity, I think it's called Babinski sign. Okay, very well done, Nabila. So you've done your homework. Now, these are the questions that you all have to discuss as a team. So please discuss these questions. If you want, you can take you have the scenario already. So it's in your scenario in the document that we gave to Megan, I think. So there are 6 questions that you need to answer as a team. You'll be presenting this at the end, and Dr. Dave will be giving you feedback on your answers. So this is the perfect opportunity for you to discuss as good as possible about these issues that are related to head trauma. So the first question you need to discuss is, what are the most likely differential diagnosis for this case? So please feel free to discuss with your friends. If you see a patient come into the ED or emergency department with a left side hemiparesis or weakness, what is the first thing that comes to your head? Okay, so we know that he has a history of head trauma. So you probably have some differentials based on trauma, but are there any other differential diagnosis that comes to your head when a patient with left-sided weakness presents to you? So perhaps start with that. And then second, what tests do you think you will need in order to aid the diagnosis? And 3, what is the mechanism behind the patient's condition? What is the appropriate therapy? Indication for surgery? When do we operate on the patient? And what sequelae or leftover problems can occur for this patient after the head trauma? Okay. Dr. Dave, do we go through the question one by one, or do you want them to discuss independently?
Thank you, Dr. Gita. Okay, I think in the discussion, the participants were asked one by one their opinion to find out whether they understood correctly or not. Because in the class C, there were only 19 participants, so they have enough time, Dr. Gita.
Thank you, Dr. Dave. So here, does anyone want to start? Before you start making your presentation, we can have a small discussion first together, just to see if anybody is not clear with anything. Does anyone have any maybe differential diagnosis that they want to come up with?
Yes, Doc. So for me, I think from the case, I think we can conclude that the differential diagnosis that we can think is hematome subdural and epidural because of the trauma capitis.
Okay, you can write that down, Megan, if you agree. Does everyone agree with that differential from Adrian? So he just suggested that you write down epidural hematoma, subdural hematoma, because there was a history of trauma. That was Adrian's rationale for choosing epidural and subdural hematoma. Now I want to ask Haki, what is your differential diagnosis? You need to give something different. Maybe one more differential diagnosis or 2 more, and then we'll move on to the next question.
Yes, Doc. Maybe we can conclude that contusio and commotio cerebral. Cerebral.
Okay, contusion or commotion of the cerebrum. Okay, maybe one more.
Okay. Maybe stroke.
Stroke. Okay.
Maybe Dr. Gita, please you type. Okay.
So that was epidural hematoma, and then subdural hematoma, and contusion. What was from Haki?
Contusion and commotion cerebral.
And also the final one is stroke. Okay, are we happy with 4 differentials? Okay, let's continue with the next question if everyone is happy with the differential diagnosis. Now, the next question, what additional exams or tests do you think you will need to confirm your diagnosis?
I think we can add a CT scan, Doc.
CT scan. Okay, great. Okay, I think that's a correct answer. Now, we've done a CT scan based on Adrian's suggestion. So Dr. Adrian has suggested that we go for a CT scan for the patient, and this is the result. I've put in some markers just to ease interpretation. So this is the right side, and this is the left side of the brain. Now, I want to ask Rizka, Amalia, what is your interpretation of this non-contrast CT scan? What can you see? Before you conclude that it's a hematoma, that is a conclusion. But what can you see from this CT scan before you conclude that it's a hematoma? So you mentioned it before. What's the shape like?
A crescent moon.
Okay, a crescent moon shape. That's correct. And on what part of the brain? Are you well aware of the regions of the brain?
Hearing.
On the right
frontal temporal
region of. Okay, so we conclude that your radiologist, Dr. Rizka Amalia, has returned the CT scan results and says that it's a hyperdense, homogeneous crescent-shaped lesion in the right frontotemporal region. And she's measured the volume for you. It's 50 cc's of blood with a thickness of 15 millimeters. And this is the conclusion from the radiologist. Does everybody agree? Well, now let's talk about the mechanism. What do you think happened?
Maybe because of the rupture, the blood fill the space between dura mater and arachnoid mater.
Okay. Good. Anyone else have anything to add? But perhaps maybe add on why do you think he had a period of unconsciousness in the first 15 minutes of his fall? Yep.
Of the brain dysfunction due to direct trauma.
Okay, so you have brain dysfunction due to direct trauma. Okay, anyone else have anything to add? Or maybe Dr. Endi, we also have Dr. Endi here with us.
Yeah, Dr. Gita.
Anything else to add, Doc, for the mechanism?
One of the causes of subdural hematoma is the age factor. This patient is 60 years old. It is possible that his brain has undergone atrophy, so that there are various empty spaces when there is head trauma from the outside. It is easy for the bridging veins to break into the arachnoid and dura mater compartments. Also can be without trauma. It can happen spontaneously if there are acceleration, deceleration, and rotation, even if it's not hard. That's the other opinion. Thank you.
Thank you, Dr. Dave. So the brain atrophy also contributes to the risk of this patient experiencing the subdural. You know the extent of the bleed is 50 cc's and 15 millimeters thick. What do you think you can do to help the patient? Start from conservative first, and then we can move on to other options maybe. Does anyone have any suggestions?
Maybe we can do the ABC stabilization, Doc.
Okay, that's good answer. Very important. So ABCs come first.
maybe we should elevate the head.
Why do you want to elevate the head?
Because there's bleeding, so we don't want the blood to go more and more to the head. I think the pressure, the intracranial pressure could increase due to the buildup of the blood.
Okay, so what we're doing here is we want to manage the intracranial pressure. And how would you do that is one option that Max mentioned was to elevate the head. Any other options, do you think? How else can you reduce the intracranial pressure?
You can give mannitol.
Okay, you can give colloids such as mannitol. What else can you give?
Natrium chloride.
Okay. Any kind of natrium chloride? Sodium chloride, right? Not natrium. Sodium chloride. What kind of sodium chloride do you think you'll give? Just the normal one you give to any patient, or is there a specific one that you can give for people who are at risk of increased intracranial pressure?
The high concentration of.
What is a high concentration, do you think?
I think it's 3%.
Okay, good. So we can perhaps consider these as options for therapy in the patient. Okay. Does anyone know why would you give hypertonic solutions like this for the patient? Why would these solutions decrease the intracranial pressure? Go back to your biomedicine lectures. Biochemistry. Why do you think mannitol and sodium chloride in high hypertonic percentages can decrease the ICP? Larasati, what do you think?
Is it like osmolarity, something like that? I'm not really
About
sure.
the osmolarity. Okay, so this is a good example of conservative management. Okay, but what other management can you give to the patient? Besides conservative therapy, what other kind of therapy can you give to a head trauma patient like this?
Surgery.
Surgery. Okay, good. Now let's talk about that now. What is the indication for surgery, do you think? Does anyone know? Did you watch the video? What is the indication for surgery according to the guidelines?
If the volume, maybe Vena can.
Maybe if the volume of the subdural hematome is more than 40 or 40 milliliter, and then or of more than 5 millimeter with GCS more than 6, maybe Janice can continue.
Pass the ball to Janice. GCS more than 6. What else do we need to make sure of before we operate?
If the function of the brainstem is still fine.
Okay. Why do you think we need to do that?
Because if I didn't get it wrong, I think like it's supposed to be like they can like the brain could like absorb the blood, but like if they're I'm sorry, doc, I don't really understand it that much.
Okay, maybe just go back to that the fact that brain surgeries to evacuate the hematoma, to reduce the blood, to evacuate the blood from the brain. It's a high risk surgery, and if your patient is in a bad condition, in other words, if it's hopeless to do the surgery.
Okay, because Dr. Gita had a problem. His house was out of light, so I took over temporarily. For our case, see this case, the history of the fall from a height of 3 meters is very extraordinary, which is not in accordance with the patient's condition, which should have hit the head with a fracture or rupture. Then the condition must have fallen into a state of severe coma. But this didn't happen because of glucose coma scale still 15. The only complaint was left hemiparesis with a strain of 4 and only passed off 15 minutes. Yeah, unconsciousness, just 15 minutes. So what about the symptoms of fainting 50 minutes 13 days ago at the time of the incident, before being admitted to the hospital, and after the 11 days there was only left hemiparesis and a mild to moderate headache, meaning these symptoms progressed slowly with no lucid interval symptoms. And after a head CT scan, a subdural hematoma was found. So in this case, there are two diagnoses: commotio cerebri and subdural hematoma. That's my explanation. Thank you.
Doctor?
Yeah. Okay, please give your the other opinion.
Okay, doctor. Maybe I give additional information about the anamnesia. We can predict what is the diagnosis from the anamnesia. Maybe 18% that can guide to the final diagnosis. We see the patients have symptoms from the trauma is jadi sesuai dengan itu ya hukum Monro-Kelly, di mana kalau otak itu kan terdiri dari tulang, ada terdiri dari parenkim, terdiri dari darah juga, ada LCS ya. Jadi ada yang solid, ada yang padat, ada juga yang cair. Nah, kompensasi di sini kalau tulang itu nggak bisa dirubah, parenkim otak nggak bisa dirubah, darah pun juga yang ada nggak bisa dirubah, yang bisa dirubah ada LCS-nya. Begitu. Jadi harapannya dengan kita memperbaiki posisi saja sudah bisa membantu pasien itu menurunkan tekanan intrakranialnya. Kedua, yang penting adalah kita harus meng-head up pasiennya dengan derajat yang pas.
Ya, bagaimana Dr. Gita? So, Dr. Gita, do you have any opinion more?
Thank you for the opportunity. I'm really sorry for connection issue. I just managed to find some signal over here. I think Dr. Endi has probably explained almost everything you need to know about subdural hematoma. Hello?
I think it's okay, yeah. Today the about discussion, it's okay. Do you understand, all of you, the participation from students?
Yes, it's already clear, Doc.
We close the meeting, ya.
Terima kasih.
See you.
Terima kasih
Okay,
banyak,
see you.
Dok.
Terima kasih banyak.
Thank you, Dok.
Dok.
Banyak, Dok.